about 1,000 patients a month in our state who have tracheostomy inserted. At Austin Health, we have about 100 patients who have an insertion and another 100 who come in with trachea already in situ. Our numbers in Victoria data for tracheostomy are showing slight decline over the last 4 or 5 years, primarily because our culture is that we no longer or rarely put tracheostomy in progressive neurological patients. Primarily, we will use non-invasive ventilation. But interestingly, the slide on the right shows that our serious adverse events are not decreasing. They are in fact staying the same, and in some years, like 2010, we had a flu epidemic and serious adverse events were very high. Thank you. Next slide. So we say that here in Victoria, in spite of the fact that there are a lot of tracheostomy tubes or teams around, we need systems change. There are pockets of expertise and leadership, and certainly that is great news, but we feel that we need standardization and certainly more coordination and collaboration in the state of Victoria. Thank you. The next slide. Patient story is, this is Gerald Stevenson. He is a remarkable man who had a terrible fall and became a C1 level tetraplegic patient, and he's fully ventilator dependent. He came to one of our other hospitals initially and came to our Center for Spinal Cord Care. He was and is an author, a teacher, a businessman, and I have to say he's a change leader. Next slide, Melody. You can see Jared while he's in the ICU, and you can see him with his family as he's ready to go out into the community to one of our ventilator-assisted support services, and he has diaphragm pacing. On the bottom left, he is speaking with our Premier, and the Premier said to him as he's leaving, "What are your ideals or goals now that you're being discharged from the hospital?" He looked right back at the Premier and he said, "I want to become a taxpayer." That's the kind of man he is. He went on to develop a blog of 1,500 followers, and now it's probably 2,500 followers, and he is selling his books, telling his amazing story. And the other reason I say he's a change leader is because when Brendan McGraw and team came over here in 2014, he was in the hospital and he spoke with them. Brendan's team said, "Man, you were talking very soon and early and so forth." And Brendan's team took some of those changes of things that we were able to implement in Melbourne back to London or back to Manchester and made some changes with his team. You can see Jared there with his family, and his sons are basketball players. They are in the US on scholarships, and Jared's next goal is to get over there. So no doubt he'll meet our colleagues in the US. Next slide. You know that the mission is to improve global tracheostomy care everywhere, and that our hashtag says it all, better tracheostomy care everywhere. Thank you, Melody. Next slide. In terms of sharing the journey, I think our journey in TRAMS has been exciting, but it's gotten 100-fold times more exciting once we joined the collaboration. We started in 2000 with deaths on the ward. We were able to show good outcomes in terms of significant reduction in time to communication, length of stay, and duration of cannulation. And in 2007, we became core business. We are a funded tracheostomy team at Austin Health. We published our outcomes, offered the first inaugural tracheostomy symposium back in 2011, and we were contacted by Dr. David Robertson in 2012 if we would participate in forming the Global Tracheostomy Collaborative. And to those of you who are even thinking about joining, I'll tell you, it changes everything. The rollouts were fantastic. The worldwide membership is so exciting. And I'm going to tell you about some of the differences it's made at Austin Health, even though we had a very established team. Next slide. Collaboration is so important, and we share resources. We share resources on the Global Trachea site, on our TRAMS site. Brendan's site is remarkable. And I wanted to show you, just in terms of power, our emergency tracheostomy management package, the scenario that's on there, has hit 63,000 views. So the collaboration that we are all doing is incredibly powerful. Next. If you look at this is a slide that simply says that TRAMS at Austin Health is a very integrated service. And one of the really exciting parts for everybody in our hospital is the GTC. And that has a very important impact on every meeting we have, every presentation we do. And I would encourage others to think about using the GTC logo and the GTC presence to really make a difference at your site. Everyone is excited once you've joined something internationally. Thanks, Melody. Next. We put our patient stories forward at every turn. This is Colin, whose story is on the GTC site and the TRAM site. He was submitted for an award in our center. If you haven't heard his story, you must listen to it sometime. The link is there and on our sites. Thanks, Melody. Next slide. Partnering with patients and families is something that's has become increasingly important and increasingly well done within the GTC and at TRAMS, and it's just so powerful. So with the GTC arm, we are offering patient and family committee through the GTC, and that's a tremendously powerful committee of our organization. We offer patient and family support and forums at Austin Health, and as well as a newsletter. In 2017, we had 2 patient and family forums, which were incredibly exciting. We shared patient stories. We presented awards for living or thriving in the community with a tracheostomy. Patients are directing their own care, and there is huge power in the collaboration when we have 30 patients and their families in one room together. We had the GTC make a tape and join us electronically, which was very powerful. Next. Sally is a collaborator. Her picture is in the front there. She has a neurological disease. By nature, when someone comes to her bedside, if it's a cleaner or someone who's delivering the meals or one of the doctors, she motions to you to come and have a picture taken with her, and she wallpapers her room with the collaborate of patients working with the staff, and it's very exciting and certainly more powerful than the pain and suffering of being in the hospital for as long as she has been. Next. David has mentioned the webinars. They're very powerful. At our center, we watch them live when the time frame is allowed, or we view them later together. And I would suggest that that's a fantastic way of collaborating at your own center. Next. We've talked about the symposiums, and once again, the scientific and the patient and family sessions are where the high energy and the inspiration is. Next. I wanted to tell you that Jared Stevenson, who you heard about at the beginning of the presentation, sent one of his books, which is called Standing on the Shoulders of Giants, over for patients in Dallas. Those books were presented to patients in Dallas, and the inscription said something along the line of, let's share the string of my story. If you know someone who needs some inspiration, or if you know someone who could benefit from my book, please pass it along. So the collaboration of patients goes across continents and is very powerful. Next. Partnering with patients is where the gold is, and I know I go on about it, but I honestly can't tell you how much of a difference it has made over here, that the more we engage with patients, the more we learn. And we would invite all of you to become inspired and energized together with your patients. Join the GTC and use their stories to tell your executives and so forth how to make a difference. Next. The database, could I have the next slide, please? Our adverse events, we are drilling down into our adverse events, which is very powerful information that we didn't have before that we now have from the GTC. And again, the next one. Accidental decannulation, for instance, we can now tell you whether the tube was replaced uneventfully or if there was transient hypoxia. And this is very powerful data to share with clinicians. Next slide, please. Similarly, with reasons for tube obstruction, we can look if it was a mucus plug, which everybody always says it is, or was that tube in fact malpositioned, and we could learn from that. Next. We've now trying to partner with Safer Care Victoria. Our aim is for outstanding safer tracheostomy care for all of our Victorians always. Could you please click the next one? By scaling statewide the globally recognized GTC and trams, and we have suggested that we would have next partner with the Victorian government to create VTRAC, which is Victorian Tracheostomy Resource Center of Excellence. We've had the nod of support, and we'll see where that goes. But I'm going to segue now to Brendan, because we would really like to duplicate some of his work that he has done with other centers in the UK. Thanks so much.
Okay, thanks, Tanis. So Melody's just going to stick my slides up. So my name is Brendan McGrath. I'm an intensive care consultant that works in the UK. So my slides start about 2/3 of the way down that deck. I think, Melody, if you could just fast forward to the big Union Jack, there's a clue where my slides start. So it's Tuesday night in the UK. It's raining. That's fairly typical for Manchester, where I live. Thank you to the organisers for asking me to say a few words about what's happening in the UK, and thank you to our sponsors for allowing us to run this webinar series. So we're all on here because we want to make care better. In the UK, we've had some evidence of problems with tracheostomy care, but also some great examples from individual institutions of how we've actually improved care. I've got a few slides, Melody, if you can find them, that would be great.
Yeah, Brendan, I've given you privileges. Can you advance with the arrows?
I cannot. Maybe you better take the privileges back and
okay.
yourself.
What is the slide that does it have your name in it?
Great big Union Jack.
That's the British flag, Melody.
Oh, sorry.
Good way to do it.
Okay, I think we're still in Tanis's. Okay, sorry.
No problem. I'll keep talking. We were helped by a couple of national reports, which, because as Tanis has already alluded to, that this idea of collaborating and sharing information and sharing stories was really important. And we knew things weren't going so well from a number of local incidents and a number of local reports. But we had a couple of national reports in the United Kingdom, which really helped us understand what those problems were. We also recognised very early on the importance of understanding the patient perspective in all of this. And it's very interesting, as Tanis says, when you speak to patients about what's important to them, it's often very different to what we were wrestling with, you know, trying to make sure that equipment was provided at the bedside, trying to make sure that patients were managed in the right place. But when you ask patients, they were expecting safe care. What they wanted was the quality of care, and they didn't really care what type of fibre optic scope we had hanging on the end of the bed, whereas we'd spend 6 months discussing it. And so what we went on to do was recognise that power of collaboration and going round and stealing the best examples and best ideas from hospitals that were doing it better than we were. The GTC gave us a mechanism to do this effectively by getting in touch with hospitals in the UK and all around the world. And as Tanis has explained, a great example of that was when we went down to see what was happening in the tram service in Melbourne. We were able to pinch some of those ideas and to bring them back to the UK and start implementing them very rapidly, going back to what David said, without having to wait for a publication or something to appear in the journal. Some slides, fantastic. So if you can just flick on 2 slides, Melody, that'd be great. So we've done that one. So this was us collaborating with people all around the world. So here we are right now. So the presence in the UK. So understanding the problem, we think we got a pretty good idea from some of those publications that I talked about, both from a UK perspective and from an international data. Collaboration, or pinching the best ideas from other institutions, as we've coined the phrase, and then trying to make changes in sort of organised ways. And we've used that experience that David alluded to about how to make changes. So having some quality improvement expertise can really help. And if you went to any site trying to improve tracheostomy care, quite often people will know what they should be doing, what they want to do. But trying to make that change is really difficult. And so having this all wrapped up with a collaboration where you can phone a friend, ask for some help, see some resources, find out how somebody did it, learn about a site that maybe things haven't gone so well, it really is powerful, and it can allow you to make those changes very rapidly. If you could just flick on the next slide, please, Melody. And what we wanted to do in the United Kingdom was to try and understand, firstly, could we drop the GTC into our NHS and see if it would make a difference? And so we secured some funding to trial membership of the GTC in 4 diverse hospitals in the northwest of England. And what we found was that within 12 months, we could have an impact on the safety of care, on the quality of care. Care was more effective, more streamlined, more efficient, leading to reductions in length of stay. And it also then led to a significant cost saving. And we put a very crude estimate in there for 300 patients in 12 months in 4 sites, not too far from me. We saved about £430,000, which is probably about $500,000, depending on how low the British pound has dropped today. What we found that if you just flick on the next slide, please, Melody, was examples of reducing harm. So all of these trends were able to be reduced. And we also found that you could reduce or have an impact on, as I say, length of stay, but things which were important to patients. So such as faster vocalization, faster time to oral intake. And so using the ideas and the resources from other hospitals around the world, we were able to bring them to the NHS, and we were able to show that we could make a difference. Could you just flick on the next slide, please, Melody? So we think the future is bright for the GTC, and certainly bright for the GTC in the United Kingdom. We've attracted funding and support for the project in the United Kingdom from a number of the Royal Colleges who are stakeholders involved in airway care. The Health Foundation has been a fantastic supporter and funder of our programs. And the funders can really see the value in not only delivering the improvements that we're trying to do, but also trying to understand that key question of how do you do it? And at the moment, we are part of a 20-site UK-wide project where we are dropping the GTC into those sites for 2 years and basically seeing what happens. We know already that we're having an impact on the safety of care. We know we're having an impact on the quality of care, similar to those metrics that we saw in the pilot study. But we're also learning an awful lot about how we do it, how we involve our patients and families, how we make those small changes through small steps that can really have an impact system-wide. And our plan in the UK for the future is to use that intelligence and to use these results to pitch membership of the GTC as an NHS-wide strategy, because we're pretty sure we can show that the quality and safety of care can be influenced by sharing these ideas and implementing them and making changes. We can also almost certainly show we can save an awful lot of money, which is not our primary goal, but it falls out of high quality care. And that, of course, is attractive when you start thinking about scaling this up to regions and to countries. So that's all I wanted to say. I will hand back to David.
So to clarify, Brendan, when you say NHS-wide, for some of our American viewers, what you're talking about is basically every hospital in the country is the goal.
Yeah, we have a state system in the UK, so there are, I think, about 240 NHS hospitals, some big, some small, around the United Kingdom. So it's our public sector. And
can we go back to my slideshow, please, Melody? Brilliant. Okay, so that's kind of where we are right now. A lot of very, very exciting things happening in the last 5.5 years. And let's talk a little bit about the future, and then let's talk about any questions you might have or how we might be able to help you make things better, and ideally how we'd help you join the GTC. We don't want to lose sight of the ultimate goal, which is, go back please. We want everybody to have best tracheostomy care everywhere. Now, we don't anticipate that every hospital in the world is going to join the GTC. But what our goal is, you can think of the GTC as a very, very big demonstration project. And we want to demonstrate so clearly and so unequivocally with data, which we publish and share, that this is the right way to do things, that over the course of time, this becomes a standard that hospitals are really expected by accrediting agencies and by the departments of public health or by their national agencies to either be part of the GTC or to do the things that we want people to do, whether they join us formally or not. So let's not lose sight of the big picture here. We want to make things better, and I want to make things better in my hospital. Brendan wants to make things better in his hospital. We want to help you make things better in your hospital. But those are all important goals. But we also want to run a very powerful, large-scale, worldwide demonstration project that makes it impossible for hospitals to ignore these set of practices. Next slide. In the immediate goal, what we'd like to accomplish in the next year or two is we'd like to increase our membership, and probably most importantly, we'd like to continue. Our patient and family membership has really exploded over the last year and a half, and we'd like to continue to get as many patients and families as we can involved. There's an incredible untapped desire to participate, desire to help, desire to see things get better. It's hard to find a patient who has a trach or a family whose child has a trach that are not aware that some things are not perfect, to put it mildly. And there's just tremendous energy here. And at the end of the day, this is what it's about. And patient and family energy is something that's going to carry hospitals and professionals to join. We do want more hospitals to join. Our goal over the next short-term few years is to grow from about 50 where we are now to about 100 hospitals. And we certainly want as many healthcare professionals as possible to join. Any of you whose hospital isn't going to join, please join as a healthcare member. We have made great strides in our data reports and our data analytics. Tana showed you some of that information. We are going to be doing that at a much finer and more granular level. At the moment, our comparisons are not perfect in the sense that you can compare yourself to another hospital, but if your patients are twice as sick as that hospital's, the comparison is not perfect. We're going to be building a risk stratification over the next year or so that we can really let you know, based on your patient population, how you're doing and whether you need to improve or whether you're already a superstar. We are going to be publishing data in the near future, and we want, for those of you who have a research bent, we want in the next couple of years to open up our database to create a process where if you want to look at a specific question, you can apply. If you're a member hospital, you can apply to access the GTC database to do specific research projects. Next slide. Somewhat more longer term, at the moment, we have focused almost exclusively on acute care hospitals, and there's a very good reason for that. That was a huge mountain to climb. It's been an unbelievable amount of work done by dozens and dozens of people all around the world, completely for free over the course of 5.5 years. And we are now at the point where I'd say it's pretty clear that over the next year or two, we'll be able to say we've climbed that mountain, and we will not have fixed every problem in every hospital, but as an organizing entity, as a quality improvement collaborative, we're getting close to a place where the picture for our long-term hospital improvement is stable, I would say. Longer-term hospitals have very different care models, and it's not necessarily the case in a long-term care facility that there's 10 different specialties seeing the patient every day. And there's some changes we need to make and some more understanding we need to have about long-term care facilities before trying to deploy our program to them. In some places in the world, in Australia, and also in some specific hospitals in the US, acute care hospitals are tightly linked with long-term care hospitals. And we have a number of our member hospitals are doing things in their associated long-term care hospitals, and we're really excited about pulling that together. And then we all know that some of the really, really important things, both good and unfortunately bad, that happen to patients in their own home. And that's another big mountain to climb. We are really excited about what we've done in the acute care setting, in the long-term care setting. We are committed to figuring out how we make sure that every patient at home with a tracheostomy gets best care. But that's going to be another big mountain. It's going to be a big challenge. And that's something we're going to be working on over the next few years. Next slide. So what we have saved some time for is you may just have questions in general about about any aspect of our presentation or anything you'd like to ask us. What can we do for you and your patients? How can we assist you in joining? And give us comments about our direction and our energy and where you think the critical areas are moving forward. You can, I don't know if we can give our participants phone privileges. I think you're going to have to type in the question box. Did we get any questions in advance, Melody?
We did not. No.
Okay. So we'll give you guys a couple minutes to type some questions in the question box. If anybody can't access, let me give you my cell phone number if for any reason you can't access that question box. I'll say this twice slowly, 617-460-6674. Feel free to text me a question. 617-460-6674. While we wait, let me ask Tanis. Tanis, you are Austin Health, your acute care facility is tightly linked and sends patients back and forth pretty seamlessly between your acute care facility and your long-term sort of what we might call in the US a rehab hospital or tell us your thoughts about deploying the GTC in, say, more freestanding long-term care or rehab hospitals.
Happy to do that, David. I think the interesting thing in Australia, I'm not sure about the UK, is we have networks of hospitals. In our particular one, we are 3 campuses ourselves. At Austin, we have the acute care, a rehab facility, a long-term rehab facility, and we are linked to a ventilator associated service in the community. The bonus of that kind of approach, of course, is that patients can move seamlessly, often with the same staff. But the structure of the tram service and the structure of the GTC, namely having experts in every center who work as a team, is incredibly helpful. We can follow our patients in terms of data by looking at the various dates that our patients put into the GTC database, and that's extremely helpful too. So we do share our information about the GTC and our processes across all campuses and across all disciplines. We also established something called an interdepartmental tracheostomy forum, which runs 3 times a year, and that is a forum where anyone who has any with trachea, and that's a lot of disciplines. David always says the tracheostomy tube is the cross-section or a piece of plastic at the cross-section of 9 disciplines. So those 9 disciplines come together and we give a GTC update at each one of those meetings. We share data, we share risk analysis, we look at specific case histories. So that's another way. David, I would also like to comment that while we're waiting for people's questions to come in, the database committee is extremely active, and we are currently looking at version 3 of the GTC database.
I'm going to make you a presenter so you can talk.
Okay, hang on a second. Let's let Tanis finish.
Thank you. The GTC version 3 database will be based upon a GTC survey that we're sending out to all member hospitals, and we would invite input from anybody who has ideas about how to change the current database so that version 3 is better. Thank you. That's what I wanted to share. Okay, so we have 3 questions pending. One is Taylor from China. How can Chinese hospitals join the GTC? You would send an email. I tried to just, do you see a response to that? I tried to send a response. You can go to our website and get the email address, but let me say that email for you. It's admin, ADMIN, at globaltrach.org. And the answer I typed actually was incorrect. So let me try again. Admin at globaltrach.org. You can find that on our website.
and send us. We'd love to have Chinese hospitals join. We have talked to a couple Chinese hospitals, but haven't been able to get traction yet. But it would be really exciting for us to get into that, into the Chinese market, healthcare space, because we know you have zillions of patients, and we think that many of them can benefit. And likely it's something that would be, if your hospital in China were to be one of the first hospitals to join, it would probably give you a lot of credibility and brownie points with the administration, et cetera. Okay, I have a question from a pediatric hospital as a respiratory therapist from Minnesota. Is anyone aware of pediatric long-term care facility? Well, at Children's, we have a rehab facility called, I work at Boston Children's. We have a rehab facility called Franciscan's Hospital. And since we joined the GTC, one of my partners has started going there regularly and doing trach rounds from an otolaryngology perspective. One of the pulmonologists was already going, but we're now doing that from an otolaryngology rounds. And we actually have the capacity now, if a patient needs a procedure, and if they need a procedure in the OR, they're going to have to come back to our main hospital. But if they need a bronchoscopy and exam in the OR, we can actually get that done in the long-term care facility, which is a huge win for, an impaired 3-year-old who doesn't have to be put in an ambulance with a ventilator and transported and admitted to the hospital in order to have and then sent back in an ambulance the next day. And if there's anybody on the call who is working or implementing principles in pediatric long-term care facilities, you can type that in the questions box, you can type that in the chat box, or you can send me a text, and I'll say again, David, I'm sorry, 617-460-6674. And to my original questioner, the pediatric respiratory therapist from Minnesota, unfortunately, this is not a very dynamic means of interacting. If I answered your question, great. If not, send me another text and we'll try to flesh that out. Now we're going to go back to our third question. Diane, you've been waiting very patiently. Looking for ideas to outreach the community for better trach care. Diane Randall is at Joe DiMaggio Children's Hospital in Florida. It's a huge pediatric hospital, and she's just completely turned things around there in the 3.5 years since they joined the GTC. Put a ton of protocols in place, built a trach team, multidisciplinary collaborative care, et cetera, et cetera. So Dan, maybe we have made you a presenter, so you are now able to talk. If you have a microphone, it would be really great if you were able to speak, or if your computer has a microphone. If not, how about type a follow-up to your question so that I know that you don't. But
okay, I think I've been unmuted. We also have, to answer the last question, we also have 2 extended care facilities that are strictly pediatric, just because we have such a large population of pediatric tracheostomy patients that are unable to stay at home. And what we did several years ago was Sam Osterauer and I actually went to these facilities and gave our speech about the Global Tracheostomy Collaborative. We talked about the trach bundles, and we talked about basic safety standards for tracheostomy. So that was one thing that we did. We have a huge population here. One of the things that I did earlier this month was I went to the EMS system in Hollywood, Florida, and I used Brendan's National Tracheostomy Safety Project and taught them that, and they were blown away. They had no idea that we have that type of population, and when that population calls 911, that they are then responsible for it. So I'm looking for ideas to try to outreach to more of these families. If anybody's got any ideas on how other things, I would love to go to home care companies, but there are legal aspects of it that, you have to worry about. If you go outside of your institution, then you have to worry about the legality of teaching someone, and just some other ideas, because I have found that the families are the biggest advocates out there.
One thing this is David again. One thing my old boss used to do was to personally to talk with the family, determine which EMS station, 911 ambulance or fire truck in America. I don't know how it works in the UK and Australia, but in America, many times the fire station actually is the first responder before the ambulance arrives. And he would have the family identify which fire station or EMS station was going to respond, and make sure that the team there was trained and that they looked at their duty roster so that there was always somebody. And certainly, Diane, that would feel like something that maybe all of us should think about doing. You know, again, as you say, the families are the ones who are motivated, and if we were to all be reaching out to families and saying, do you know who's going to answer? Not if you call 911, do you know who will come? And let's work with them to make sure they get appropriate training. That would be one thing. And then another idea occurred to me, but I'll let it pass. Taylor from China, if you want to type your email in the question box, I will reach out to you personally. And anyone, if you'd like to set up a phone call and learn a little bit more, or to get any more information, if you just want to type out your email in the question box, I'll be happy to reach out to you. If there's anyone in the group, Tanis and Brendan, I'm sure you have some thoughts, but if there's anyone in our audience who has thoughts about how we reach out to patients who are in long-term care facilities or who are living at home that you'd like to share with Diane, please start typing and let us know your thoughts. Brendan,
Diane, you go ahead, Dave. Mm-hmm.
Brendan, you run a huge operation now. You have like 24 hospitals participating. Have any of those hospitals started to reach out into the community in terms of their trach population, or do you know?
Yes, so we're very lucky. We've got some of our exemplar sites are participating in our QI project, and so we've been in classic GTC style, taking the sort of best bits and trying to implement them in some of those hospitals, including my own, that maybe aren't so good at looking after our patients in the community. And it's a huge challenge, even understanding on a sort of national scale how many patients are out there, where they are, what sort of facilities patients are in. Is a logistical big challenge, and it's a huge source of stress for patients and families when it comes to being discharged, and it's a huge source of frustration for our institutions when they're trying to place patients. So, as you highlighted there, the next obvious step for the GTC is to try and take some of those exemplar sites, some of those examples of transitioning patients effectively into the community, and understand how we can all do that. So yes, we have got some sites that do that very effectively, and we're trying to spread that at the moment.
What do you have any specific thoughts for Diane that she might be thinking about?
I think
Diane has built a really cool discharge process. There's a form that I believe, Diane, in your institution, families are actually given a ticket, and they have to get all the boxes checked off, and the family is sort of the monitor of whether everything's done based on that checklist before they leave. Is that correct?
Yes, it's called a ticket to ride, because if you call it a test, then they get nervous. So it's just kind of like, it gives me an idea of how if they understand everything that they've been taught, so we can move forward. So that kind of helps with that. But we have a formal tracheostomy education process where we go through everything step by step, because you don't just go home with the plastic tube in your neck. You have to go home with a lot of different equipment too. But my biggest thing that I like is I ask the families what works best for them, because you know, most of us are trained professionals and we learn at a different pace than some of the families do. So a lot of them have asked us to like either slow it down or put it in different terms or make it much more simple than what we would do. And that's their contributions have helped me enormously.
But your question was more about, so this is great, you've built this great process that as the patient walks out of the door, all the boxes are ticked. and at least we hope they've learned everything they need to do, and you check that with them. But your question, I think, was more about once they're out the door, what
Yes.
thoughts does the group have about reaching out or continuity or services we should be providing in the community? Brendan, do you have any thoughts about that?
I'm not sure we can answer that in what's left of this webinar. It's a huge project. I think you need to understand your local area, your local facilities. Yeah, I think that's a big piece of work.
Sure.
I think, to be honest, Diane would be the person to be advising me.
You know what? I am so sorry that due to the way this screen is organized, I have missed out on a couple. So let me go to Ricky Williams. One of the presenters stated mucus plug is a common problem, but we experience more dislodged trachs and find we have to replace, most likely from transferring and repositioning. Do you have best practices for transferring and repositioning? So what I'd say to that is GTC doesn't, for a lot of reasons, doesn't get into the granularity of we think you should use a certain brand of trach, or we think you should change it on day 5, or we think there's a right way to transfer the patient. One reason for that is once we start, it's hard to close the door on that, and to make recommendations about best practices that people might follow. There's a lot of legal liability, and it actually is you have to go through a huge process. I couldn't just, the GTC would not be a good idea for the GTC to share with you David's best idea about transferring patients. Many of our member hospitals have protocols for transferring and repositioning, and if you post something, if you join as a healthcare member or just send me an email address or send me an email, we can post that on our web discussion board, and we can point you in the direction of what other hospitals have done. But the other reason that we don't make too many specific recommendations is it seems to be that one of the things that makes protocols work is that people take the trouble to build their own protocols in their own institution. We don't think it seems to work very well to simply download other people's processes. We would be, Ricky, again, send me an email, or I'm so sorry I didn't see because of the screen here, I didn't see your comments earlier. But send me an email or post or join as a healthcare professional and post on our website, and we can tell you a number of our hospitals who have publicly available protocols. Tanis's protocols in Melbourne are all publicly available and easy to get to. We can show you how to do that. And I think we've collected a number of other protocols from hospitals willing to share, and are happy to give those to you, of course. Ricky, if you want to tell me whether I answered your question or there, that would be great. I see your email address, and I will send you an email. We have about 4 minutes. Any last questions or comments? Brendan or Tanis, you don't want to say something exciting to wrap us up?
I think it's exciting how far we've come. I think it's nothing short of remarkable in 6 years, the amount of collaboration, the amount of perspiration that's gone into the project to get it this far. And I think it's going to be incredible to see what happens over the next 5 years. We are well set to accomplish all the things that you listed. And I totally agree that the patients in the community are a big challenge. The TRAMS website has a protocol. All of our discharge information is also on our website, which is not dissimilar to what Diane has done. But the real goal here is to be able to discuss with colleagues and have contact with people who are doing things differently and who can support us. So collaboration is remarkable. Thank you to David for his remarkable idea.
Yeah, I mean, I think what we're going to see over the next 5 years is pretty much what we saw in the first 5 years. We're going to change the world, and we're going to have a ton of fun. And if your facility can join, or if you can join as a healthcare professional, please do so, and we'll have fun together. That gives us 2 minutes to go. I'm going to declare the webinar over. I will monitor questions for another couple minutes, but we'll let you go, and I see some of us are already going. Thank you all for your attendance. It was wonderful to have you here. Really enjoyed talking with you.
Bye, guys.
Thank you.
So what we could do is wait a minute. If we wait 2 minutes, everybody may be gone and we might be able to talk among ourselves for a second. Brendan, you and Tanis have time for that? Or have you gone? Brendan and Brendan's gone. So I guess we're all wrapped up, Melody. I'm going to sign off then.
Okay, sounds good. Thank you, guys.
Thanks, everyone.